صدري ويسر واشرح لي لو اشرح لي صدري ويسر لي امري احلى من لساني فوق قولي. I will just start. We'll talk about today the heart failure, specifically chronic heart failure. I'll give you briefly about definition, classification, NYHA and stages, comparison between the two, some concept about hemodynamic and progression of heart failure, the heart failure burden, the trajectory of heart failure and our goal of management, and the drugs which used in heart failure. And we'll talk about briefly about some guideline and recommendation, and when to refer these patients to the advanced heart failure programs. And at the end, we'll summarize some summary. The definition, the voice is clear?
Yes, boss. Okay.
The definition of heart failure, as all of you know that the heart failure is not a disease by itself, it is just a syndrome characterized by typical symptoms that may be accompanied by sign caused by structural and or functional cardiac abnormalities, usually result in reduced cardiac output and or elevated intracardiac pressures at rest or during exercise. And you know that the elevated intracardiac pressure, we can test it with non-invasively or invasively. And this usually results in reduced exercise capacity and neuroendocrine activation and impaired quality of life. And the new universal definition of heart failure classified the different phenotypes according to the ejection fraction. And this is endorsed by different societies, European societies, American, Japanese, Indians, Chinese, and different societies now adapting this definition. And this is the new universal definition upon the ejection fraction. We have the ejection fraction 40 or less, that is reduced ejection fraction. And here you need to have sign and symptom to diagnose the heart failure. And the clinical prerequisite is very important for diagnosing, not only looking to the numbers. And then you have previously called mid-range, now they call mild reduced between 41 to 49, in addition to symptom and signs and elevated biomarkers. With preserved ejection fraction, that is ejection fraction 50 or more, again with sign and symptoms and elevated biomarkers. The and presence of structural findings supporting the diastolic heart failure. The fourth entity, which is called heart failure with improved ejection fraction or recovered ejection fraction. This is type of reduced ejection fraction, and there is increase in the ejection fraction more than 10 points, and the new ejection fraction is more than 40%. This is dealt like reduced ejection fraction. As we will see later, we should continue the medical therapy and we should not stop. And then the diagnosis of preserved or mild reduced ejection fraction, there is should be an evidence in addition to symptoms and sign of spontaneous or provocable increase in LV filling pressures, that is elevated natriuretic peptide, non-invasive and invasive hemodynamics. Non-invasive, as you know that we do it in the echo by looking to the left atrial size, the LVH, the tissue Dopplers, and we look at, to them as a whole. And then in the diagnosis of preserved ejection fraction or mild reduced, the diagnosis approach start with assessment of pretest probability. These are the clinical characteristics. The diagnosis should include the following. You have the clinical features, symptoms and sign of heart failure, LV ejection fraction 50 or more, and there is an objective evidence of cardiac, structural, and or functional abnormalities consistent with presence of LV diastolic dysfunction in the form of raised LV filling pressures, including raised natriuretic peptides. Again, I should remind you, if somebody had ejection fraction more than 50 and previously labeled as reduced ejection fraction, this is not considered preserved ejection fraction. This is continue with reduced ejection fraction treatment. And this is a general, the echo parameter which we see whenever we looking for the patient with sign and symptom of heart failure and normal ejection fraction. We look to the LV mass index, and in female and male are different. In female, more than 91 gram per square meter, and in male, more than 115. And then the left atrial index volume. And as you remember previously in the echo, it was 28. The cutoff now is 34 ml per square meter. This is in somebody in the sinus rhythm with no atrial fibrillation, and there is no valvular dysfunction. If there is atrial fibrillation, then the cutoff for the LV volume index should be more than 40. And then the E to E prime ratio at rest, and the cutoff more than 9, but the sensitivity here is high, but the specificity is low. But if we took the cutoff to 13, then we have lower sensitivity, but higher specificity. And then you have the elevated natriuretic peptide or biomarkers, and you have elevated PA systolic pressure. And this is have a sensitivity of 54 and a specificity of 85 in the presence of heart failure preserved ejection fraction by invasive testing, and that is the pressure more than 35 millimeter of mercury. So you have to look to these parameters. Is there any difference between the term is NYHA and staging? Yes. Staging is one-way direction, while NYHA class is back and fro. In staging, this is indicating, ring a bell for the patient and for the health care provider. Stage A, that at risk, if you have any risk of developing heart failure, hypertensive, diabetes, smoker, family history of ischemic heart disease, and you have no symptom at all. You have only the risk factors, and functionally the heart is totally normal, systolic, diastolic, valves. So everything is normal, but you have the risk factor. They call it stage A, or they call it now pre-heart failure, at risk of heart failure, sorry. And then we have stage B, which is pre-heart failure. We said this is the one-way direction. In addition to the risk factors, still there is no symptom. There is the risk factors, and there is an evidence of structural heart disease in the form of reduced ejection fraction or preserved ejection fraction feature by echo, hypertrophy, chamber enlargement, wall motion, valvular disease, and there is increased filling pressure by invasive or non-invasives, and then elevated natriuretic peptide, persistently elevated cardiac troponin also, it can be a marker. And then we come to the stage C, which is symptomatic. Once you develop symptoms, it means that you are labeled as stage C. Even if you're now is asymptomatic at one time in your lifetime, patient being is asymptomatic, then he will be labeled as stage C. He will never go back to stage B. He may progress to stage B, but he will remain, even if he recovers, still we call him stage C. Advanced, very advanced or marked heart failure symptoms that interfere with the daily life, with recurrent hospitality despite optimum attempt to optimize the guideline-directed medical therapy. This is advanced and needs special care. NYHA, as we mentioned, that NYHA class, New York Association class 1 is asymptomatic. Ordinary physical activity does not cause symptoms. NYHA 2, ordinary physical activity causes shortness of breath and fatigue. And NYHA 3, less than usual activity causes symptoms. And at 4, that is symptom at rest. If anybody have a question during the presentation, or there is something not clear, you can stop me at any time. And this is the hemodynamics, and it goes with the staging of the heart failure and symptoms. Normally, if you look to anybody, his stroke volume, you will see here, you have the stroke volume, you have the end diastolic pressure. This is normal up to here, and you have the LV end diastolic volume. In normal people, stroke volume, end diastolic pressure, the end diastolic volume, all are normal. And then in pre or stage B, pre-heart failure, still stroke volume is normal, end diastolic pressure is normal. Maybe end diastolic volume slightly increased, but still patient is asymptomatic. Once the end diastolic pressure is getting elevated, if you see here, the marker is clear for you, then patients start developing symptoms. And this is, by the way, even patients with very low ejection fraction, sometimes we see them with no symptom. But if you look to diastology, we'll find their diastology and diastolic pressure is totally normal. So once you develop elevated end diastolic pressure, then the patient is getting symptomatic, and there is markedly increase in end diastolic volume. Once the patient goes to the advanced, which is stage D, you will find the systolic pressure is low, pulse pressure is low, stroke volume is low, the end-diastolic pressure is significantly elevated, as well as the end-diastolic volume. And the heart failure is, as we said, that is a chronic disease. And the patient with chronic heart failure, he is either compensated, chronically compensated, or chronically decompensated, or is compensated with some episode of acute decompensations. The patient who is compensated with each episode of decompensation, there is a significant increase or lead to high rates of hospitalization and increased risk of mortality. With each decompensation, the rate of hospitalization increased, and there is the risk of mortality also increased till patient die. And the heart failure have a significant global disease burdens. There is a more than 60 million patients worldwide have heart failure. In 2016, heart failure was responsible for almost 80,000 deaths in the United States, and approximately 50% of patients diagnosed with heart failure will die within 5 years of diagnosis. And the heart failure is one of the leading causes of hospitalization and considered #1 cause of hospitalization for people aged 65 years or more. And readmission rate after each hospitalization for heart failure is as high as 30% within the first 2 to 3 months. After the first hospitalization, there is increased 30% during the next 2 to 3 months readmission. Approximately there is 30% patient die within 1 year after hospitalization for heart failure. The neurohormonal activation, as you know that initially it may be beneficial, raising the blood pressure, increasing the cardiac output, but the long run is harmful. The neurohormonal activation plays a central role in the pathogenesis of heart failure. This was led in the clinical trial to development of RASI groups, RNA, ACE inhibitor, ARBs, MRAs, and beta blockers. It is the end journey. Luckily, this is not the end of the journey. New drugs are coming in the pipeline, like SGLT2. There is still, despite this improvement in medical therapy for heart failure, there is still unmet needs to improve the care of the patient with heart failure. Despite the availability of therapies, the 5 years mortality remain high, and the heart failure with the ejection fraction till today, there is no class 1 medication recommendation for such group of patients. Why optimization and new treatment is required? Despite use of heart medication, patients remain at risk of cardiovascular death and heart failure hospitalization. That is why we need more medication. What is the trajectory of class C heart failure? The class C heart failure patient, either their new onset, de novo, newly diagnosed with no previous history of heart failure, or there is a resolution of symptom. He's a chronic resolution of symptoms. Either he stage C with previous symptom of heart failure with persistent LV dysfunction, or he may come in remission with improvement of symptom, even of recovery and functional status, or the symptom persists and there is sign and symptom of limited functional capacity, or he go very advanced or worsening his symptoms. And why we need to treat this patient? The patient usually we need them to live longer, which is prognosis, the reduction of hospitalization to stay out of hospital, and improve quality of life, or having less symptom. And if you cannot offer all of them, at least give a comfortable end of life support. The potential drug for heart failure, there is quadruple therapy, which is considered class 1, like RASI group, angiotensin, ARBs, and then there is sacubitril valsartan. This is RNA, or you have aldosterone antagonist, or the beta blockers, or SGLT2. The diuretics always is class 1 recommendation in congested patient with for all type of heart failure, reduced, mildly reduced, or preserved ejection fraction. The second line class therapy, these are some of the second line class for therapy, the hydrolysine nitrate, especially in the Black African Americans, or ivabradine in somebody with a sinus rhythm with a heart rate more than 70, or the digoxin, somebody with an atrial fibrillation and still not controlled despite optimal medical therapy, and Risdiplam was soluble guanylate cyclase stimulator for the patient who have frequent admission or frequent need of diuretics. This is some of the landmark trial in patients with heart failure. I'm not going to through it. And this is the diuretics goal. What is diuretic dose? We need to give it to the patient. Usually diuretic, the aim of it to improve symptom, and we should use the minimum dose to reduce congestion or to make patient like dry, but not hypotensive, to achieve the dry weight as the nephrologist use this term. So the minimum dose make the patient decongested. This is our aim, because the higher doses, it may not allow you to use the medication which have survival benefit or reduction of hospitalization. Remember always, regarding diuretics, remember pre-discharge, clinical congestion at discharge is a strong predictor of poor outcome and readmission rate. So before you discharge your patient home, be sure that he's decongested. Any remaining congestion is a marker for readmission, early readmission for the hospital. These are some clinical trial for the ACE inhibitors: consensus, SOLVE treatment, VHEFT, and then you have SOLVE prevention. All of this showed the evidence in the clinical randomized clinical trial, and this is the major clinical trial done in beta blocker. Copernicus, CBIS, Copernicus for carvedilol, CBIS for the bisoprolol, and MERIT heart failure for metoprolol, long acting, and senior trial done for Nebivolol or Niblet. So we have 4 medication used with evidence-based in heart failure for beta blockers. The cutoff ejection fraction is different from each one, but generally we use the cutoff like 40% or less. And this is the MRAs used in the symptomatic heart failure with LV systolic dysfunction. We have RAILS trial, we have emphasis heart failure trial with emphasis trial, and the RAILS trial was the first one. Ejection fraction was 35 or less. Again, it was from class 3 to class 4 symptoms. Emphasis trial, the symptom for class 2 and ejection fraction less than 35 or less. And the emphasis trial is slightly different. It is post myocardial infarction with LV ejection fraction 40 or less, and symptom of heart failure or history of diabetes. And all of them proven to be, they have reduction in mortality, reduction in hospitalization, and survival. This is the SHIFT trial for the ivabradine, which is called the funny receptor blocker. Ivabradine showed in the SHIFT trial. Always you have to remember the clinical trial for the patient with ejection fraction less than 35, symptomatic, NYHA class 2 to 4, with a recent hospitalization in the past 12 months, and patient is sinus rhythm more than 70 beats per minute sinus rhythm. We don't use it in somebody with atrial fibrillation. So it showed reduction in hospitalization and reduction in heart failure related mortality. But this should be on top of optimal guideline directed therapy of beta blocker or maximum tolerated dose of beta blocker. And then we come to ARNI, Entresto, neprilysin as a therapeutic target. We know that neprilysin breaks down endogenous vasoactive peptide, which is beneficial. And this is vasoactive peptide, including natriuretic peptide. Inhibition of neprilysin potentiate the action of this peptide. But among these, peptide is angiotensin 2. These all are beneficial. The angiotensin 2 is harmful. So once you do inhibition of neprilysin, this increase in the blood. That is why the ARBs valsartan is used to block the effect of angiotensin 2. Was the combination of neprilysin inhibition and angiotensin receptor blockers is the first one? No, it was not the first tried. Before that, there was a combination of neprilysin inhibition and AC inhibition. It was tried, but it was have unacceptably high rate of angioedema. That is why this trial was stopped prematurely. So because we said that because the angiotensin 2 is also substrate for neprilysin inhibitor must be co-administered with RAS, which is the valsartan. This is a paradigm heart failure primary result in cardiovascular death, primary endpoint, or heart failure hospitalization, CV death, and all-cause mortality. It showed the positive result in all the 3 major areas. How to initiate the guideline-directed therapy? Initiating with new onset stage of heart failure C, whether to initiate beta blocker or an inhibition of the renin-angiotensin system. Usually, you check your patient, see if your patient is dry or wet. If he's dry, maybe you start with beta blocker, but if he's wet, then you start with RASI group. Generally, now we have the concept of the old concept of sequential, and there is a new concept of simultaneous and rapid titration of the medication. This is the new concept, simultaneous use of medication, the fourth pillar of the heart failure. We'll show it later. Then we'll ask a question. What about patient with improved ejection fraction? Should we continue guideline-directed medical therapy or reduce it, eliminate it in the patient with complete recovery? This is the question. Somebody with reduced ejection fraction and now he recovered. Should I stop? Should I reduce the medication? What I should do, or should I continue? There is a trial which is called withdrawal of pharmacological treatment for heart failure patient with recovered dilated cardiomyopathy. A study examined this question. The finding that nearly 50% of subjects withdrawn from the guideline-directed medical therapy had an heart failure event within the coming 6 months. So the bottom line, I think we should continue this medication. Therefore, in the absence of defined reversible cause for heart failure, reduced ejection fraction, tachycardia example, mediated cardiomyopathy, currently guideline-directed medical therapy should be continued. And this is SGLT2 group, which is again becoming class 1 in reduced ejection fraction. And again, it is class 2A in mildly reduced and preserved ejection fraction. And this is empiric outcome. And this is the first trial which showed these drugs have a benefit of heart failure. Risk reduction between the placebo and empagliflozin was 35%, and hazard ratio was 65. And this is DABA heart failure, primary composite outcome. Again, the dose of dapagliflozin plus placebo with reduced ejection fraction. DABA showed reduction in cardiovascular death and worsening of heart failure compared to placebo. The safety profile was consistent with that in the previous studies. And the DABA heart failure, this is again for the worsening events and for the cardiovascular death. And showed again reduction by 30% and cardiovascular death by 18% reduction. The effect in a meta-analysis for DABA and empagliflozin, the effect of empagliflozin and dapagliflozin on heart hospitalization were consistent in the two independent trials. And this suggests that this agent also improve renal outcome and reduce all-cause and cardiovascular death in patients with reduced ejection fraction. And generally, these drugs, SGLT2 inhibitors, initially they cause worsening of the kidney function, but with the passage of time, the kidney function improves. This is the meta-analysis, almost 8,500 patients in both groups, and they found that the SGLT inhibition was accompanied by 26 relative fluid reduction in combined risk of cardiovascular death or first hospitalization for heart failure. And the risk of the composite endpoint was also reduced. Of the renal endpoint also was reduced. The pooled treatment effect showed consistent benefit for subgroup based on their age, sex, diabetes, treatment with ARNI, or baseline estimated GFR. And then what about patient who's getting worse symptoms, frequent hospitalization, requiring frequent IV diuretics? They studied the drug-soluble guanylate cyclase stimulator, Verziguat, and there is another drug called cardiac myosin activators, omecamtiv. And in this Verziguat, in Victoria trial, Verziguat increases soluble guanylate cyclase activity to improve myocardial and vascular function. And in this trial, they assessed whether Verziguat reduces the primary composite of cardiovascular death or first hospitalization, and the result showed positive result. This is the group, ejection fraction was less than 45, somebody with chronic heart failure, symptomatic, and guideline-directed medical therapy, or recent worsening symptom. So what happened? The new recommendation, they found this drug is beneficial. It's not a class 1, but they recommended that Verziguat, an oral soluble guanylate cyclase stimulator, to be considered in addition to optimal heart failure therapies in somebody with reduced ejection fraction with worsening symptoms and hospitalization for heart failure in the past 6 months to reduce the risk of subsequent heart failure hospitalization. The question, why usually patient does not get the guideline direct medical therapy? There is a term called clinical inertia. Doctors say that my patient has mild symptoms, no need to increase the medication or to add medication. My patient is stable, why to change? Evaluate my patient when he get more symptoms. It is not convenient for my patient, or some doctors, they consider SGLT is not their drugs, which is considered for diabetes. This is the Canadian Cardiovascular Society recommendation. If you see here, they reduce ejection fraction 40 or less. The first line therapy all simultaneously, ARNI or AC or ARBs, then substitute for ARNI. Generally, ARB is superior to AC or ARBs. If cost an issue, then you prefer to go for ACE inhibitor. But if it's not an issue, always go with ARNI. And ARNI you can substitute for the ACE inhibitors. The only area here, if somebody ejection fraction less than 40, he never had heart failure at all, and it's not stage C. The benefit here is doubtful, but somebody at stage C, then R is superior. Beta blockers, MRAs, as this GLT, these are the first line recommended medication. New recommendation, we recommend that in the absence of contraindication, patient with reduced ejection fraction to be treated with combination therapy, including evidence-based medication for each of the following 4 groups. And this is a strong recommendation. And this is here. Then once you give the class 1 recommendation and the patient is still symptomatic, you go to the class 2 recommendation. Again, we said that somebody in sinus rhythm is still symptomatic, the heart rate more than 70, despite optimal medical therapy and tolerated dose of beta blocker, then considering adding ibuprofen. If somebody had recent heart failure hospitalization requiring IV diuretic, consider Risdiplam. If somebody is still symptomatic, consider his self-identified Black African American, or he's unable to tolerate ARNI or AC or ARBs, there's consider combination of hydralazine and isosorbide dinitrate. The rate, the heart rate, if suboptimal rate, control of AF is difficult or persistent symptom despite optimal guideline, then consider adding the Digoxin. And the quadruple therapy now considered is the new standards of care for heart failure reduced ejection fraction. Building foundation for new era of quadruple therapy in heart failure. And this is again, it tell you about this all class 1 and replacement of the replacing ARNI for ACE inhibitor or ARBs is also class 1 and a level of evidence is P. This is here cumulative impact of evidence-based heart failure with reduced ejection fraction. If you look at it, start from up. If you don't give anything, the 2 years mortality almost certified. If you give ACE inhibitors or ARBs, then the rate of reduction 23%, while the 2 years mortality dropped down to 27%. If you add on beta blocker, then the rate of reduction is 35%, and again, the 2 years mortality dropped to 18%. If aldosterone antagonists were added again to the group up, the relative reduction is reduced to 30%, and the mortality is dropped down again to 13%. Added ARNI for replacing the ARP or then the relative reduction is 16%, while the 2 years mortality dropped to 10.9%. SGLT2 added again 9.1%. Till we reach that, the number need to treat is only 3.9, and significant absolute risk reduction is 25.9%, which is a significant result, while the rate of reduction is almost 74% using all the combination of the 4 groups. Benefit of initiating ARNI, beta blockers, MRAs, SGLT2 simultaneously for heart versus historical sequencing. So the new guideline encourage using simultaneously and rapid titration over a period of few weeks. So the simultaneous use and rapid titration of the medication is starting from the hospital admission. Rapid lead to rapid improvement in the health status within 1 to 8 weeks. Rapid reduction in heart hospitalization within 2 to 4 weeks. Rapid reduction in mortality within 2 to 4 weeks. Rapid improvement of LV ejection fraction within 12 weeks. Rapid reduction in heart failure rehospitalization with 2 to 4 weeks. and lead to improved use, adherence, and persistence, and overcoming inertia. So now we should adopt simultaneously and rapid up titration of the medication, starting from the in-hospital admission. These are the doses of medication. I'm not going to through it, okay, including all the 4 groups. And this is, it tell you about the second line generation, additional therapy for heart ejection fraction, additional therapy. If somebody, again, we said that his reduced ejection fraction, sinus rhythm, heart more than 70, on maximum tolerated beta blocker, you add ibuprofen. If patient is still symptomatic, ejection fraction less than 45, recent heart failure hospitalization, or IV diuretics, elevated diuretic peptide, then you add virziquat. Symptomatic heart failure with ejection fraction, despite optimal medical therapy, you may add digoxin. Heart failure with NYHA through BUVA have some evidence. Patient with heart failure with hyperkalemia, while taking RASI group, to enable using RASI group, you can add potassium binders. Okay. And what about the device therapy? The ICD recommendation and CRTD. There is a little difference between American and European Society of Cardiology. In patient with non-ischemic dilated cardiomyopathy or ischemic heart disease, has at least 40 days post-myocardial infarction with ejection fraction less than 35 or less, and symptomatic on maximum on chronic guideline who have reasonable expectation of life more than 1 year. Always should be to put a device, should be on guideline therapeutic therapy, and there is symptomatic and expectation of life more than 1 year. ICD therapy is recommended for primary prevention of sudden cardiac death. This is here. Class of recommendation is 1 and level of evidence is A. So it's strong. If patient had 40 days post-myocardial infarction, his ejection fraction is lower, 30 or less, with no symptom or class 1, while receiving guideline who had reasonable expectation of life, again, this is class 1, level of evidence is B. And for patient with ejection fraction 35 in sinus rhythm, left ventral branch block, QRS 150 or more millisecond, and symptomatic, or ambulatory class 4 on guideline, CRT is indicated to reduce the total mortality, reduces hospitalization, and improve symptom and quality of life. This indication, you know, it was early CRT when it started, the cutoff was 120, then went to up to 130, and then went now to 150 to consider it class 1. So if somebody have non-LBB, similar ejection fraction 35, with QRS 150 or more, and symptomatic or ambulatory class 4 symptom on guideline direct medical therapy. Since he is non-LBB with wide QRS, the CRT is considered class 2A with level of evidence B, useful to reduce total mortality and reduce hospitalization and improve quality of life. If somebody he had ejection fraction 35 or less, left ventral branch block, QRS less than 150, between 120 and 149, symptomatic, or NYHA class 2 to 3, or ambulatory class 4, the CRT can be useful. Now is considered also 2A to reduce mortality, reduce hospitalization, improve symptoms and quality of life. This is again continuation for non-LBB button. Again, the QRS 120, the guideline drop down to 2B, and similarly, if it is LBB with a similar QRS duration, it is class 2A, while here non-LBB group is considered class 2B. For patients who have ejection fraction less than 30% or less, ischemic cause of heart failure, sinus rhythm, left ventral branch block with QRS more than 150, and NYHA class 1 symptom on guideline CRT may be considered to reduce hospitalization and improve quality of life. Here, his patient is asymptomatic. No benefit in patient with QRS less than 120, CRT is not recommended. So here there is no benefit. Now we come to valvular heart disease. We have usually the two valve disease, aortic stenosis, and we have the mitral regurg. The preferred studies support the recommendation summarized below. In patient with heart failure, valvular heart disease should be managed in multidisciplinary team or heart team or cardiac team according to the guideline for valvular heart disease to prevent worsening of heart failure. In patient with chronic severe secondary MR, reduce ejection fraction with optimal guideline medical therapy, it's recommended before any intervention for secondary related LV dysfunction, we have to consider the heart team. So here, again, the recommendation for ejection fraction, the mildly reduced ejection fraction 41 to 49. Again, as I mentioned earlier, diuretic always is class 1 in somebody congested. SGL2 is class 2A. The rest is ICR, ARNI, MRAs, and evidence-based beta blocker are class 2B. And this is similarly in somebody with ejection fraction 50% or more, reserve ejection fraction. The diuretics congested, class 1. The SGLT2, class 2A. The rest is class 2B. When we should consider sending patient to advanced heart failure program? If the patient, somebody had repeated hospitalization, emergency department visit for heart failure in the past 12 months, need of intravenous inotrope therapy, persistent symptoms, severely reduced exercise capacity, big VO max less than 14, or less than 50 predicted of the age group, or the 6-minute walk test less than 300 meters, or inability to walk one block on level ground because of dyspnea or fatigue, or there is intolerance to RAS inhibitors because of the hypotension or worsening renal function, or there is intolerance to the beta blockers because of the heart failure symptom or hypotension. Recent need to escalate diuretic to maintain volume status, often reaching daily furosemide equivalent to more than 160 milligram per day, and need for adding supplemental thiazide like metalazone therapy. And there is refractory clinical condition, progressive duration in renal function, worsening of heart failure secondary to pulmonary hypertension, systolic blood pressure less than 90, cardiac cachexia, persistent hyponatremia with sodium less than 134, refractory or current ventricular arrhythmia, frequent ICD shocks, increased predicted 1-year mortality by more than 20 according to the heart survival model. And at the end, I have few questions. Maybe everybody open his mic. I will ask and need to answer. You have a patient here. For any question now, or I just go for this is the end of the lecture. I have few questions posted this time for you. Open your, make it unmute. Hello?
I have a question regarding frequent admission. How many to be considered as frequent admission?
I think frequent admission, more than 2 hospitalizations in the last 6 months considered frequent admission.
Okay, thank you.
Yeah. We go to the questions, or there is more?
Question.
Yes, okay.
First, actually, I have 2 questions. Ejection fraction sometimes is an operator dependent. So shall I have another way to assess the function of the heart rather than ejection fraction, like stroke volume, for example? My second question, if you I have to choose between starting dapagliflozin or ARNI. Sometimes these drugs might be of financial cost and burden on many patients. If I have to choose one of them, shall I go with dapagliflozin and AC inhibitors, for example, or shall I introduce ARNI first?
Okay, for the first question, all the clinical trials done on depending on the echo by ejection fraction. But definitely there is some superior method of checking the ejection fraction. As you mentioned that the ejection fraction is operator dependent. Sometimes there is variability of 5, even up to 10 points. But generally the clinical trial done on the echo. So I cannot tell you to use another method. But if you have facilities, you can do the MRI, which is more accurate for checking volume and ejection fraction. If you have facilities, or sometimes the bed stress, they can tell you about accurate about ejection fraction. The second question regarding, favoring ARNI or SGLT2 over the others, the cost is always an issue. In a country like Sudan, example, sometimes patient will not afford to get all the medication together. So that is, I think, depend on the clinician and decision to decide. Generally, if you ask me, somebody have no cost, then I will use the ACE inhibitors and DABA to get the cost down if the cost is high. Okay, if the patient can can afford, then I can give the whole medication, depending on and this is needed discussion with the patient. Make the patient also center of your decision, not take decision in behalf of him. Sometimes we take decision we consider he cannot tolerate, but you know that health is the most important. So if you told him this is may recover your LV function, he will tell you, okay, I'll buy it. Don't worry. So tell him and let him share the decision with you. Any other question? I hope this satisfies satisfies your question.
Yeah, thank you. Thank you very much.
Hi, I would like to ask a question about management of heart failure with reduced ejection fraction in setting of end-stage renal disease, prognostic medication, as it depends on GFR like this. What is the policy and CKD?
Okay, for the example, you know that the RASI groups, now there is a lot of evidence for the RASI group. I mean by RASI group, the inhibitors, ARBs or ARNI. Even not only for heart failure, they are useful for the even advanced CKD. But the issue here, you will face the hyperkalemia. And if you have the facilities and you can use the potassium binders, you can use this medication, but with the close follow-up and also close watching the kidney function. The recommendation generally, the kidney function if increased by more than 30%, then you need to stop this medication. This is regarding the group of RASI group, I mean ARNI, ACE inhibitor or ARBs. Regarding the SGLT2, the cutoff for estimated GFR use, it was in the clinical trial was done up to 20 GFR. But if you started with GFR of 20 and there is a slight drop initially in SGLT2, I think you have to continue and watch, because sometimes there is a dip in the kidney function initially, the drop in estimated GFR, but later on they found that this patient, their estimated GFR improved. So you have to be a little bit courageous to continue this medication. But again, I say this is need a very close follow-up, and you have facilities to see the patient frequently with checking his potassium and the kidney function.
Sorry, Doctor, just on the last point you mentioned, is this for both acute kidney injury and CKD? Have to apply this rule?
No. Acute kidney injury, definitely. If you have somebody who started medication and acute kidney injury, then you need to stop the medication. And if you want to restart it again after recovery, you have to start gradually, because you want to know. Sometimes the acute kidney injury is not because of the RASI group. Maybe you over-diuresis. It happens very frequently. Over-diuresis, or somebody is getting, non-steroidal anti-inflammatory drugs or some other toxic medication, nephrotoxic medication. So before you deprive the patient benefit of this good medication, you should look for the others harmful medication or other causes of worsening kidney function. Sometimes patient, because of the hypotension, because of the over-diuresis, because of use of non-steroidal, especially the elderly with osteoarthritis, knee problems, shoulder pain, they use this medication, or sometimes they use the herbal. So before you deprive him for the good medication, I think you need to look for the other causes. But definitely if you have acute kidney injury, there is no clear cause for that. I think you need to stop the medication, and if you want to introduce it after recovery, introduce it gradually with close observation.
Okay, thank you.
Dr. Hatem, you have any comment about this?
I can comment after you. That's so comprehensive and well explained. Thank you so much.
Yeah, Sheikh. I go to the question, or somebody had more question? The time is okay?
Yeah, the time so far is good. You can carry on.
Okay, so I will bring this question and I need somebody to answer. You have a 45 years male. He's known with a higher heart failure ejection fraction, optimal medical therapy, visited your clinic with no symptoms. His last echo ejection fraction improved to 50%. Yani mean that he recovered from, and already stopped his diuretic because he doesn't need it. His systolic pressure is borderline between 100 to 105 millimeter of mercury. What is your next recommendation? Do you do CMR, cardiac magnetic resonance imaging, to confirm his ejection fraction? Or you stop all his treatment for heart failure reduced ejection fraction, you stop ARNI because of low blood pressure, or continue the medication? So this is from the presentation. Which one you will go for?
To continue.
To continue. Okay. And then the second question here, you have a 76 years male although I did not touch this topic very clearly, male hospitalized for congestive heart failure with high BNP. His cath, we cath him and we showed his currents are normal. After initial stabilization, we did an echo for him. We found ejection fraction is 30, and there is a ejection systolic member, and we found that his mean aortic valve gradient is 25 milliliter of mercury. Aortic valve area is 0.8 square centimeter. His stroke volume index is 28 ml per square meter. What is your best next step? Do you do the vitamin stress echo, or you do CT for aortic valve calcium score? You do transvagal echo, or you do surgical aortic valve replacement, or you do trans approach aortic valve implantation? Tabi.
The vitamin stress echo.
You go with the vitamin stress echo. What is the reason why?
Low flow, low gradient.
Low flow, what is the cutoff for stroke volume index?
Low flow, low
35.
gradient. 34.
35, exactly, 35. So here,
34
the area is okay, go is severe, but it can be false because what will happen if this is true AS? Maybe this will present for you in the valvular lectures, but generally, if it's true AS, the area will remain the same, the gradient will increase, even ejection fraction will improve, and the stroke volume index also will improve, but the area will not increase, and the gradient will also increase. The third question I wrote it to, 67 years old male with non-ischemic cardiomyopathy, symptomatic, NYHA class 3, on optimal medical therapy, ejection fraction 30, he's had normal RV function, severe functional MR, RVSP, and he had a pulmonary hypertension. His ECG is sinus rhythm, his left ventricular branch block, QRS 150 millisecond. What is the best next step? Do CRT, do mitral valve clip, surgical mitral valve repair, surgical mitral valve replacement, increase the aortic dose.
CRT.
CRT, okay. But if you send it to interventionist, you will put the mitral valve clip. So never ever send your patient to interventionist before you manage him properly. Agree, Hatem?
Of course, I agree.
طيب, الquestion اللي بعده, which statement related to SGLT is correct? Is contraindicated if the GFR less than 60, or SGLT does not affect the renal function, only recommended in heart failure reduced ejection fraction. They may cause transient decrease in renal function that should not prompt their discontinuation.
Only recommended in heart failure. Reduce ejection.
Pardon? Oh,
D.
there is the answer. Somebody said the reduced
correct.
ejection fraction, somebody said D. The
D.
correct
Sorry,
answer is D.
Yes.
Yes.
As we mentioned earlier, it is class 1, level of evidence A in reduced ejection fraction.
Yes.
It's class 2A in mildly reduced or preserved ejection fraction. So you use it in the three categories group, reduced, mildly reduced, or preserved. But definitely the use initially drop in the kidney function, and you have to be brave to keep it, and then you will see the improvement in the kidney function. 55-year-old woman developed LV systolic function dysfunction. This is a chemotherapy related. I did not touch it, but just I brought this question. Systolic dysfunction to ejection fraction 45% during anthracycline chemotherapy for breast cancer. Which drugs or drug combination should be considered? Amio, candesartan and amiodarone, furosemide and bisoprolol, ramipril and carvedilol, and valsartan. I did not touch this group, but I just brought this question.
D.
Yes, combination of ramipril and carvedilol, they studied and they're protective. In summary, this slide summarizes all of this lecture in reduced ejection fraction. We have the 4 pillars for heart failure. We mentioned that this group include the RASI group, which is neprilysin inhibition, ARNI, Entresto, and or ACE inhibitors, okay, or ARBs. So usually the first line is ARNI, Entresto. The second line is ACE inhibitor. The third line, if you cannot afford both of them or intolerant to both of them or the financial cost, and there's cough, then you can use ARB. But the first line, ARNI, Entresto, second line ACE inhibitor, and the third line ARBs. in sequence. Then you have the beta blockers. How many beta blockers in heart failure reduced ejection fraction we have?
4.
4. I just mentioned it earlier. Bisoprolol, carvedilol, metoprolol, succinate long-acting, and nebivolol, which is
Nebivolol.
called. Yes. These are the 4 medications, but please don't start nebivolol at the first drug because it is expensive and a lot of doctors, they use it. It has some nitric oxide effect and vasodilatory effect, different from others, and it is more selective, but I think expensive. So don't put it the first line. Then finish from this.
Doctor, is it superior in asthma patient?
And as I tell you, frankly speaking, this asthma patient, I think rarely we have a heart failure clinic, which is I'm looking after. We have more than 1,000 patients in this clinic. A lot of patients, they come to us labeled as bronchial asthma, COPD, and rarely we used to stop the beta blocker. Even not to stop, patient not on beta blocker, they come for the clinic, we start beta blocker and they tolerate. And rather, I come through one paper, but I forget what is the name of the trial. They found that beta blocker improved response of this patient to the bronchodilators. So rarely I found that. So I use bisoprolol, I use carvedilol, I use the metoprolol, all of them. Rarely I find a patient who's intolerant. Usually the intolerant patient for bronchial asthma, you'll find this patient on steroids or patient requiring frequent hospitalization because of the asthma exacerbation, but otherwise usually well tolerated. It could be more selective, nebivolol, yes, true, but rarely we need to do that. So now we finish from the group, and then MRAs. MRAs, we have spironolactone, ibuprofen, and the third one, another one, but not in the market yet. Then the SGLT2, we have 2 medications, DABA and IMPA. And the good things about SGLT2, you don't need to titrate. Just you have 10 milligram dose and khalas, that is, you don't need it. Then you finish from the first line medication and you go, if somebody in the sinus rhythm, the heart is 70 or more, on maximum tolerated dose of beta blocker, you add ivabradine. If somebody heart failure with atrial fibrillation, you don't need to look to Cardiovascular, you just add anticoagulant because this patient at risk of stroke. If patient on loop diuretic maximum dose and still congested, you can add thiazide diuretic like metalazone. And in the clinic patient, they consider metalazone like dawa sihri. Give it half an hour before the thiazide diuretic. So you have blocking of at loop of Henle, and then you have blocking of the distal convoluted tubules on the kidney. So if somebody frequent hospitalization or frequent require of ID diuretics, I never use it. This is what this is indicated. Iron deficiency anemia, which is you look for the ferritin less than 100 or transferase less than 20%. You give IV iron, and there is now a single dose IV iron, which is a little bit expensive. If somebody cannot get RAS because of hyperkalemia, and then you have to use a potassium binder, this is again add to the cost. If somebody labels himself Black African American and is still symptomatic or even not tolerant to the RASI groups, then you can add hydralazine, combination hydralazine and isosorbide dinitrate. And if somebody in sinus rhythm persistent symptom, you can add digoxin. So the key change is to have treatment in 2021. New class recommendations therapy for reduced ejection fraction inhibitors, DABA and IMPA. The 4 drug therapy should be initiated as quickly as safely as possible, which is, I said, simultaneously and quick up titration. Importance of tailored management, and this up titration should start from in-hospital. Primary VHCD is none. In non-ischemic cardiomyopathy now is class 2. Okay. Emphasis on the LBB broad is in selecting patient for CRTD. Thank you. Any question?